Welcome along to the latest deep dive from Pathways in Pediatrics, the official EAPS podcast. We're definitely still buzzing from the energy and insights from the recent EAPS Congress in Lisbon. Just an amazing event, really. Over 1,700 professionals, more than 100 countries represented. It just shows that huge global commitment we all share for improving child health.
It really was fantastic, a powerful gathering. And, there was so much practical, really useful knowledge shared there. So for the next few deep dives, we thought we'd try and synthesize some of the most popular, most impactful sessions for you.
Absolutely. And today, we're jumping right into a challenge that, well, it shapes our daily practice, doesn't it? The child with fever. We're going to summarize the first step-by-step education forum. This featured Professor Christelle Gross-Le Guin and Dr. Brett Burstein, and they presented on risk stratification and management strategies, a really critical topic.
Oh, definitely. It's right at the core of pediatric emergency medicine, isn't it? I mean, every single day we're faced with that problem. Is this just a straightforward viral thing, or is it something much rarer, much more serious, like an invasive bacterial infection, an IBI? It demands, constant thought and a really clear evidence-based approach.
Okay, let's try and unpack this a bit. Maybe start with the scale of the problem. The presenters, they really highlighted how often we see this. Fever drives, 10 to 15% of all admissions to pediatric EDs? That volume alone makes getting the clinical decisions right just incredibly important.
It really does. And the stats they shared, they help quantify that risk, that sort of needle in a haystack scenario. So if you have a child presenting with fever without source FWS, the data suggests a serious bacterial infection, or SBI. Now, that includes things like UTIs, pneumonia. That occurs in about 5% to 15% of those cases.
Right, 5 to 15%. That's actually, quite a significant chunk right there.
It is, yeah. But then the really severe end, the things we worry most about, like meningitis, bacteremia, the IBIs, they make up the smallest fraction. Only about 1% to 3% of those FWS cases. And it's that small percentage, as Professor Gross-Le Guin really emphasized, that creates the big management dilemma. How do you avoid the awful outcomes if you delay treating an IBI without subjecting loads of kids to overdiagnosis, overtreatment, unnecessary tests, maybe harmful procedures?
That balance is key. And that pushback against overtreatment, especially with antibiotics, is critical. We often think about immediate safety, sure, but what about those unseen consequences? What did the speakers say about that?
Well, they pointed to two big long-term threats. First, obviously, antibiotic resistance. That's a huge global health issue. We all know that. But second, and maybe less discussed sometimes, is the impact on the child's gut microbiota. Dysbiosis, they called it. And they presented some concerning links between that early life disruption and the risk of chronic conditions later on.
Yeah, what specific links did they mention?
They talked about associations between that early microbiota change and later risks of obesity, adipose, even recurrent bronchiolitis. It really drives home that our diagnostic choices right now can have these systemic health effects that follow a child for years.
Wow. And this need for precision, it gets even trickier depending on where you practice, right?
Right.
They were clear that local incidence really matters.
Absolutely. Hugely important. The data they showed on sepsis incidence, for instance, it varies massively around the world. Something like 6.2 cases per 100,000 kids in one place, up to maybe 89 per 100,000 elsewhere. So if you're going to use these risk stratification tools properly, you have to know your local epidemiology. What are the IBI rates in your specific area? The algorithm's effectiveness really depends on knowing that local baseline risk.
That makes perfect sense. Know your local context is step one. Okay, let's pivot then to the initial assessment. The first step in any algorithm. Age is obviously foundational. They mentioned incidence of SBI is about 14% before 2 years old and drops off quite a bit. But beyond age, what clinical signs did they say really stand out as high risk?
Yeah, the meta-analysis findings they shared were quite revealing on this. The most powerful signs, the real red flags, were lethargy and poor peripheral circulation. If you see those, the probability of an SBI shoots way up, often pushes it over 50% likelihood, actually.
Interesting. And what struck me was that it wasn't just about objective signs. They put a lot of weight on the subjective side of things, too.
Yes. And this is where it becomes so relevant to everyday practice, I think. The presenters highlighted that the clinician's own subjective feeling, that gut instinct that something's really not right, that emerged as a very strong risk factor. Likelihood ratio over 20, they said. And actually, parental concern is also really significant. That had an LR of 14, so listen to the parents.
That really validates clinical experience and intuition, doesn't it? But if those soft signs and the gut feeling are so predictive, why are ED visits still so often driven by just one number? How high the fever is?
Ah, yes. That's the big misconception they really wanted to challenge in the session. Okay, so while a high temperature is often what brings parents in, the intensity of the fever itself, it's actually not a useful sign for telling viral from bacterial infections apart. You can't rule out an IBI just because the fever isn't sky high. You can't confirm it just because it is. The focus always needs to be on how the child looks, their clinical appearance, circulation, work of breathing, not just the number.
Right. Appearance, circulation, breathing. Okay. So focusing on appearance then leads us naturally toward the lab tests, the biomarkers for risk stratification. The speaker seemed pretty clear that the old total white blood cell count should probably be, well, abandoned in favor of better markers.
They were quite definite, yes. They stated that CRP, C-reactive protein, and PCT, procalcitonin, are definitely superior. But PCT seemed to have the edge, especially in certain situations. It's released more specifically in response to bacterial endotoxins, and it performed better than CRP at identifying IBI, particularly with very early fevers, maybe only an hour or two duration. They suggested a key cutoff point of zero point 0.5 nanograms per milliliter for PCT.
Okay, zero point 0.5 for PCT. So if PCT is the better marker, that brings us to Dr. Burstein's point about the differences, the friction maybe, between international guidelines, especially around lumbar punctures, LPs. That's always a big discussion point.
It is, and it raises that difficult question about standardizing care versus trying to de-escalate, doing less invasive things when possible. Dr. Burstein pointed out a major difference, the new Canadian guidelines from 2023. For low-risk infants under 1 month old, they no longer recommend doing a routine LP. Now, that's a pretty big shift away from the traditional American guidelines, which still advise doing an LP systematically on pretty much all infants in that very young age group.
Right, so the Canadians are saying, look, if the baby seems low risk clinically, the biomarkers are good, maybe you can skip the LP, which is, let's face it, a stressful procedure for everyone.
Yeah.
But is the infrastructure really there everywhere to support that less invasive approach? Can everyone get these tests quickly?
Well, that was exactly the challenge they put back to the audience. They did a live poll in the room, and only about half the clinicians there said they had rapid access, meaning under 2 hours turnaround for PCT results. And that really underlines a fundamental point, doesn't it? These less invasive strategies, the ones that maybe skip the routine LP, they absolutely depend on having fast, reliable biomarker testing available 24/7. If you don't have that logistical support, it's really hard to change practice, and clinicians might just default back to doing more tests.
Yeah, that access issue is huge. It has to be reliable and fast. Okay, let's look at the actual evidence then that supports moving towards doing less. The French step-by-step algorithm and the big trial based on it, the TED-E trial.
Right. The French algorithm, it's quite cleverly put together. It basically combines the clinical signs, the child's age, and crucially, point-of-care PCT results to quickly stratify risk. And it was specifically designed to try and avoid doing systematic blood tests early on and hopefully reduce unnecessary procedures that follow.
And the TED-E trial was massive, wasn't it? Over 8,800 kids, 24 different EDs. What were the key results? Did it work? Was it safe?
The results were really quite strong in validating that approach, yeah. They showed a 10% overall reduction in antibiotic use, and the biggest drop was seen in the youngest babies, under 3 months old. And crucially, from a safety perspective, the trial established non-inferiority for morbidity and mortality.
Okay, so just as safe.
Exactly. The less invasive approach was shown to be safe. Plus, they saw significant drops in how often blood tests and lumbar punctures were performed, especially in that under 1 month group.
That's compelling evidence.
Yeah.
Still, you can never completely eliminate risk with the tiniest infants, can you? Did Professor Grassl offer any clarification on the safety net for those under 1 month?
Yes, she was very clear on that point. Even if an infant under 1 month looks low risk, seems non-toxic, and has a PCT under that 0.5 cutoff, they still need to be admitted to hospital for clinical surveillance. So the algorithm aims to cut down on invasive tests like the LP, but it doesn't remove the need for careful observation and follow-up in that most vulnerable group.
Right, observation is still key for the very young. Makes sense. Okay, let's shift gears slightly and look towards the future. What new tools did the speaker suggest might help refine diagnosis and triage even further?
Well, they talked about moving towards tools that are rapid and integrated. Things like expanding the use of point-of-care PCR testing for respiratory viruses. Because knowing if a virus is present, as we'll touch on, really changes the risk picture. They also mentioned automated algorithms that could combine results from multiple biomarkers at once, trying to boost sensitivity and specificity. And digital tools, like the nice EAPS screening tool in the UK, to help make sure red flags are systematically checked for every child.
I was quite interested in the communication tools they mentioned too, like the Kids Kit app. How do things like that fit into managing fever?
Yeah, the Kids Kit app is designed for parents, actually. It uses decision support logic to help guide them towards the right level of care, maybe the right doctor, or whether they need the ED. The idea is to potentially reduce unnecessary emergency visits while still making sure the genuinely high-risk kids get seen quickly. It's like applying triage principles before they even leave home.
That link between communication, information, and risk seems vital. And Dr. Burstein presented some really striking data on how finding virus really changes the risk assessment in young babies.
Yes, absolutely. For infants under 60 days old, if they test positive for a common respiratory virus, think COVID, RSV, the risk of having a serious bacterial infection, and IBI, drops dramatically. He shared some studies, for instance, from the COVID waves, where the rate of bacteremia or meningitis in babies who also had COVID was basically zero.
Wow. That must be incredibly useful information for clinicians, especially during a busy winter season. A bit reassuring, maybe.
It is. It's a powerful factor for ruling things out. But there's one important caveat they stressed. Even if you confirm a virus, you should still probably do a urine test.
Oh, okay. Why is that?
Because the chance of having a urinary tract infection, a UTI, is still significant, even if the child also has a viral illness. So you can't completely skip the UTI check just because you found a virus.
Okay, that's a really important practical point. Viral positivity reduces IBI risk significantly, but doesn't eliminate UTI risk.
Got it.
All right, finally, let's wrap up the practical advice. What was the core message for parents about managing fever at home?
The guidance was very clear and direct. Symptomatic treatment for fever using paracetamol or ibuprofen should really only be used if the child is clearly uncomfortable or distressed by the fever. If the child looks well otherwise, you don't necessarily need to treat the number on the thermometer. And furthermore, the speakers really emphasized that parents need to be strongly cautioned against just treating a single fever spike at home in a baby under 3 months old without getting them checked out immediately, because sometimes that single spike might be the only early warning sign of a serious IBI.
Okay, so if we were to boil down all the insights from that really packed session at the Congress, what are the sort of 5 key takeaways practitioners should really be thinking about applying?
Sure. If we synthesize it all, the core advice seems to be this. 1, your initial clinical evaluation is absolutely paramount. Look for those red flags and trust your clinical intuition, that gut feeling. 2, use urine testing and procalcitonin, especially for early onset fever, as they're the superior biomarkers currently. 3, routine lumbar puncture should really be restricted to only the highest risk infants, following clear stratified guidelines. 4, only do an investigation if the result is actually going to change how you manage the child. Don't test just for the sake of testing. And finally, number 5, you must stratify risk using up-to-date evidence-based algorithms, but make sure they're adapted to your specific local epidemiology. Know your local rates.
That's a great summary. It really feels like the shift towards less invasive management is proven to be safe and effective now. But as you said, it hinges entirely on having that support structure, timely, high-quality biomarkers, and robust risk assessment tools. The TED Y Edway trial evidence really does reinforce why every hospital, every clinic needs to keep evaluating its own local access and resources to really deliver on this new standard of care.
Absolutely. We hope this recap of the EAPS Congress session gives you some useful points for your own practice, helping bring maybe a bit more precision to this really critical area of pediatrics.
We certainly wish you well in your continued practice. And just a reminder, if you couldn't make it to Lisbon or maybe missed this particular session, you can still log into the EAPS Virtual Congress platform right now. You can access the recordings of this session and all the others.
That's right. And we definitely encourage anyone who missed the Congress altogether to consider registering for the online access. There's just so much valuable content there to catch up on.
Thank you so much for joining us for this episode of Pathways in Pediatrics.